Pulmonary Grand Rounds. It's really my pleasure to introduce today's speaker, Dr. Mark Siegel. Really, to those of you in the audience and on Zoom, I feel like Mark really doesn't need an introduction. He's been a visible leader for the section, for the department, for the trainees. But there's a few words about Mark's journey and his amazing accomplishments. After finishing his undergraduate studies as an English major at Columbia, he completed medical school at the same institution and thereafter moved on to UPenn for internship and residency, and then ultimately came to Yale as a pulmonary critical care fellow. He's really been a Yalie since then, staying on as faculty and rapidly rising through the ranks. Mark served as MICU director between 1997 and 2007, and then as director of the Medical Critical Care Service for YNHH through 2011. It was really around this time that I first spoke to you, Mark. I don't know if you remember. It was the fall of 2006. I was a very naive, inexperienced third-year pulmonary critical care fellow at Mount Sinai, hoping to find an ICU-centric job in Connecticut. There's absolutely no jobs listed, but I sent in a CV, uninvited, not realizing there were actually plans for a MICU expansion with the anticipated opening of the Smilo Cancer Center. We got to speak on the phone and in person during my visit, and your approachability, kindness, excitement, and passion about academic medicine and critical care left a lasting impression. It wasn't one of the reasons that I came to work here. Mark has been really, his mentorship and his inspiration as a leader is where Mark really shines. He's been a fearless program director for the internal medicine residency since 2011, contributing to the career development of hundreds of internal medicine residents over the last 15 years. Giving his educational contributions, Dr. Siegel has won numerous awards, including most recently the Rosemary Fisher Excellence in GME Award in 2025. He's been a sought-after speaker locally, nationally, and regionally in a wide range of topics related to education, medical ethics, everything critical care. And as a teacher and thinker, Mark has a unique gift in his ability to engage learners and break down complex concepts. He's been involved in clinical trials in the ICU, of course, and has also widely published in high-impact journals such as Critical Care Medicine, NEJM, and JAMA. We're really in for a treat here. Thank you, Mark, again, for speaking to us today. Today's talk is titled, Zombies or Resurrection, Exhuming the Critical Care Trial Graveyard. Thanks.
Thank you, Shoko. I remember your talk when we were recruiting you, and I remember going to dinner with you. So that was memorable. Thank you, Dr. Mathey, for this invitation, and a happy Easter and Eid and Passover and April Fool's Day to everyone. Okay, so just a reminder that for CME, you can text your 53907 to this telephone number. I have no disclosures. So what is a zombie study? So I'll admit that I made this term up because I wanted to have a good audience. So I'm glad that you're here. My definition of a zombie study is that they were landmarks in their time, often quoted, infrequently read, but definitely having a lasting impact on our practice. So my objectives for today is to review 3 studies that I believe have had a major impact on critical care, explore common misconceptions and misapplications related to these studies, and hopefully derive some lessons from critical care history. I came up with the idea for the talk before I knew what I was going to talk about. So if I do an okay job today, maybe Dr. Mathey will have me back So I'm not going to study I'm not going to talk about early goal-directed therapy, daily awakening, tight glucose control, transfusions in critical care, the support study, and various biological studies related to sepsis and ARDS, such as cytokine antagonist studies and the Zyger study. These are all important in their own way. It's just I had to choose. So I'm going to discuss three very important studies. The first would be the prospective studies of indexes predicting outcome of trials of weaning from mechanical ventilation by Yang and Tobin. This is the study that launched the rapid shallow breathing index or frequency tidal volume ratio, however you prefer to talk about it, in 1991, so just before I started fellowship. The effectiveness of right heart catheterization in the initial care of critically ill patients from the support investigators by Alfred Connors, which basically killed the Swan-Ganz catheter in the medical intensive care unit, and ventilation with lower tidal volumes as compared to traditional tidal volumes in acute lung injury and the acute respiratory distress syndrome, the first big landmark ARDSNet trial, which completely changed the way we practice taking care of patients with ARDS. So let's start here. So case one, the frequency tidal volume ratio, also known as the RSBI. Imagine, if you will, a 72-year-old woman with COPD who has been intubated for respiratory failure. 3 days later, she's awake but confused. That could be Dr. Bazzani's talk, but wheezing and has decent gas exchange. And so the question that you ask yourself is she ready to wean? And this is the Scylla and Charybdis question that we ask ourselves in the ICU. If we wean prematurely, there's a risk that you'll cause complications, right? Maybe cause myocardial ischemia or extubate prematurely and have the patient aspirate. Or if you wait too long, there'll be the problems related to ventilator-associated pneumonia and being in bed too long. So it's a question that we want to ask. You want to wean the right person at the right time. So this study by Yang and Tobin, this is a picture of Martin Tobin, who is out at Loyola University now, was a landmark study in 1991 that was based on an observation that he and others made from a few years earlier. I apologize for this blurry looking slide. I had to ask for the library to find this paper for me, but this is from a study that Tobin did in 1986, where he compared a relatively small group of patients who were subjected to a T-piece trial. And what they did is he compared people who failed the trial and people who succeeded in the trial and looked at their frequency and tidal volume in addition to other measures. And so the clear circles are the people who failed their trials. They became hypercapnic or hypoxemic. The dark circles are the people who succeeded in their trials. And what you can see here, this graph, this is of the patients who their tidal volumes were lower when they failed and their tidal volumes were higher when they succeeded. And their respiratory rate was higher when they failed and lower when they succeeded. So this was the observation that Tobin made 5 years prior to his New England Journal study, showing that patients who failed weaning trials were having rapid, shallow breathing. And so what he did in the New England Journal studies, he wanted to identify optimal indices to predict weaning outcomes. And I just want to emphasize, and he talks about this over and over again, this is how are you going to do with weaning, not how are you going to do with extubation. So amazingly, this is, shows you how times have changed. This is a New England Journal study of 46 patients who were stable and deemed ready for weaning trials. They'd been on the ventilator an average of about 8 days. Subsequent decisions about extubation were made by the treating physician, and they basically calculated the frequency and tidal volume over 1 minute of spontaneous breathing through a T-piece. So for those of you who don't have an experience with a T-piece, it's basically the endotracheal tube is coming out of your mouth, and there's air flowing by it, and that creates a T, and now that's the T-piece. So you're basically removed from the ventilator. And so they defined success as the ability to sustain spontaneous breathing for at least 24 hours after extubation. So they went through the trial, got extubated, or failure being they had to go back on the ventilator or got reintubated within 24 hours. So that was the two groups that that they were studying. So this was a MICU study. So the patients were very much like patients we take care of now, a distribution of ARDS, pneumonia, obstructive airways disease, CNS disorders, heart failure, pulmonary fibrosis, and miscellaneous. And it's a little bit hard sometimes to keep track of this, but he defined a true positive, meaning somebody who had a low frequency tidal volume ratio who actually weaned successfully. That's a true positive. So if their frequency tidal volume ratio was less than 105 and they were weaned successful, that's positive. A true negative would be somebody with a frequency tidal volume greater than 105 who failed weaning. So that's how they defined that. And here was the key outcome from the table. And there's lots of indices that he studied in this trial, but I just want to focus on the key one, which is the frequency divided by the tidal volume. And what he found was that this parameter was extremely sensitive for predicting who was ready to be weaned, meaning if you were weaned successfully, you almost certainly had a frequency tidal volume ratio less than 105. The specificity was not that great. So for people who were not weaned successfully, a decent number of them also had a frequency tidal volume ratio less than 105. So translated into predictions, if your frequency tidal volume ratio was very high, you almost certainly weren't ready to be weaned. But if your frequency tidal volume ratio was lower, maybe you would. What's sometimes lost in this discussion with this sort of obsession over this number of 100 or 105 is that the accuracy diminishes rapidly over time. So when he broke down the groups, the sensitivity was extremely good for patients who were intubated for less than 8 days, but greater than 8 days, the sensitivity started to drop. Similarly, the specificity didn't change, but the positive predictive value too went down a lot. So again, if your numbers, if you were less than 105, but you'd been on the ventilator for like a week and a half or so, these numbers become a whole lot less useful. So what they concluded was that as a predictor, the frequency tidal volume ratio has several attractive features. It is easy to measure. It is independent of the patient's effort and cooperation. It has high predictive value. And fortuitously, it has a rounded off threshold of 100 that makes it easy to remember. So this is why we talk about 100, because who remembers 105? So what happened after this? So key takeaways, first of all, you're going to find that the way they did it in the original trial and how we use it now is completely different. So just remember, this number was derived from a T piece. There was no CPAP, there was no pressure support. It was a full minute of measurement, and it preceded the weaning trial. It was not like we sometimes see even now in the MICU, like a patient weans for a half hour and somebody tells you that this is what the frequency tidal volume ratio is after a half hour. That's not what Tobin and Yang did. Remember, the accuracy drops over 8 days. They did not consider patients' different patient characteristics in this study of 46 patients, like sex, size, what their disease states might have been. And it doesn't address other factors that might preclude extubation, like cough secretions and mental status. So nevertheless, it really transformed the way we think about who is ready to wean. This is also a landmark study from the critical care literature by Wes Ely, which he did when he was a chief resident down in North Carolina. And what he basically showed was that if you check patients in the ICU every day for weaning readiness and put them through a trial that was driven by nurses and respiratory therapists, that patients were more likely to get extubated faster. And this was the study that basically launched weaning trials or spontaneous breathing trials in the ICU. But one little thing that's buried in this study, which I just rediscovered in preparing for this talk, was this note in Wes's methods. He said that to measure the ratio of the respiratory frequency and tidal volume, continuous positive airway pressure of 5 centimeters of water with no mandatory breaths was used and without pressure support for 1 minute. And he acknowledges that this criterion was different from the one in the original manuscript by Yang and Tobin. So in other words, every patient that was being screened in Wes Ely's study was on 5 centimeters of pressure support. And so the question is, does that matter? the other thing is to show how things change over time. This is actually our care signature pathway for spontaneous breathing trials. And I was not involved in writing it, and maybe somebody here knows, but one of the ways that we're expected to monitor patients for failing spontaneous breathing trial, interestingly, is if their RSBI is sustained above 120. I actually don't know where that 120 number came from, but it was along with signs of respiratory distress. So as just a couple of examples of how this is used all over the literature. But getting back to this issue of does the technique matter? So this was a study by Patel and colleagues in respiratory care in 2009. I just want you to look at the bars on the left side. And what he was doing, this group was doing, is they were actually looking at what happens to the frequency tidal volume ratio when you add CPAP. And so the x-axis is just CPAP versus T-piece. The y-axis is the rapid shallow breathing index. And I think you can all see that when you add CPAP, the frequency tidal volume ratio goes down. So from an average of around 100 to the 70s. So just a word of warning to everybody here, when we keep using the number 100, as it was originally described, but then you do the trial using CPAP or pressure support, you might expect the tidal volumes to go up and the rates to go down. And this threshold of 100 doesn't really make a lot of sense. And so more recently, there was a very large meta-analysis of 48 studies looking at over 10,000 patients, looking to see how the RSBI holds up. And the sensitivity of the RSBI is kind of modest, like 83%, specificity only 58%. And these investigators showed that actually it almost didn't matter what your threshold was, whether you used 105, 80 to 105, or 80. And so a couple of years ago, the AARC, which is the Respiratory Therapy Professional Society, created a clinical practice guideline of spontaneous breathing trials and reviewed this literature. And what they basically said that they wanted to ask in adult mechanically ventilated patients, does including the RSBI predict successful completion of a spontaneous breathing trial? They reviewed the Trivedi study, which I just showed you, which basically suggested moderate sensitivity and poor specificity. They also looked at a study that Karen Burns did, who's a well-known critical care investigator, who surveyed a large number of critical care medicine physicians and found that 51% of them did not use the RSBI in their practice. So it was only about 50% of us who actually used this at all. And so the official recommendation was that the RSBI is not needed to determine readiness for SBTs, and made this as a conditional recommendation with moderate certainties. So even though this is a important study and an important, I think, way that it's affected medical practice, the RSBI is not recommended currently for critically ill patients who are weaning. So to conclude this analysis, I think that Yang and Tobin made a major contribution to critical care. They came up with a metric that allows us to describe rapid shallow breathing, which I think is a indicator of who is struggling. Caveats is that it was meant to predict weaning outcome. It was never meant to be used to determine extubation readiness. Accuracy falls with time on the ventilator, and the technique changes the frequency tidal volume ratio when you do it in a way that's different than the investigators originally used it, and that might affect the threshold. And again, it's not recommended by the AARC. So let's move on to the next big study. So how to assess and manage shocks. So I invite you to consider a 63-year-old man who is admitted to the MICU with pneumonia. He gets 3 liters of lactated ringers, but despite that remains hypotensive with a high lactate, and his O2 requirements are increasing. So question is, why is he in shock? Is he volume depleted? Is this cardiogenic? You know, one of the things I discuss a lot with my residents in the MICU, there's a tendency to say, well, they're septic, they're in shock, they must be in septic shock. But we know that that's not necessarily true, right? Like they could be volume depleted, their heart might not be working. The definition of septic shock is actually showing vasodilatory shock related to sepsis. And you don't necessarily know that just because they have an infection. So you have to ask these questions. Do we give more fluids? Should we start pressors? Should we give inotropes? And again, these are difficult decisions, right? If we give fluids when they're not going to work, you might cause pulmonary edema. If you give vasopressors that aren't indicated, you may cause tachyarrhythmias and mesenteric ischemia. If you assume the heart is working when it's not, you might miss an opportunity to intervene with inotropes. So these are all questions that seem like we want to know the answer to. So how are we going to answer these important questions? So I'm still sort of old school. I round with a clipboard, and for anybody who's rounded with me knows I get my pen out and I draw this all the time, okay? So why is this patient hypotensive? It's got to be the product of the cardiac output and the SVR. If the cardiac output is low, it's got to be the product of the heart rate and stroke volume. If the stroke volume is not where you want it to be, you have to wonder about the left ventricular ejection fraction and left ventricular preload. These are key questions that we have to ask ourselves on rounds. And the beauty of critical care for me is that you really can get mathematical like this, right? There's no way that you can be hypotensive if there isn't something wrong with either your cardiac output, systemic vascular resistance, or both. And you could just imagine that, wouldn't it be great to have a tool that explicitly gave you these parameters, tell you exactly what the cardiac output is, what is the stroke volume, what is the filling pressure, and can we derive from that what the ejection fraction is. And we're constantly reminded that shock is more than just about blood pressure. This is the classic sort of VO2-DO2 relationship, which is a talk in and of itself. But the assumption that we all make is that oxygen delivery, the cardiac output times the oxygen carrying capacity, is the relationship between the VO2 or oxygen utilization and DO2 is basically a flat line for the most part. Your oxygen delivery is just going to meet the body's needs. But if your oxygen delivery drops below a certain point, you enter the anaerobic or lactate zone, okay? You're not delivering enough oxygen. The body's cells and organs don't have enough oxygen, and they have to start to use anaerobic metabolism. And at that point, you will start to make lactate. Now, a lot of you understand that lactate doesn't just come from inadequate oxygen delivery. Mitochondria don't work in sepsis. There are type B lactic acidoses. There's microcirculatory abnormalities that contribute to lactic acidosis. But we spend lots of time on rounds, whether you articulate it this way or not, thinking about this, right? We want to know, how do we make sure the patient's cardiac output is adequate? And we're going to use interventions like fluids and pressors and inotropes in order to address this physiological problem. And we ask ourselves, like, where are we on the Starling curve? Okay, this is sort of my simple version of the Starling curve, but basically the x-axis is preload, the y-axis is stroke volume. Normal healthy people are on the ascending limb of the Starling curve, which means if you give more preload, they'll raise their stroke volume, but above a certain point, you give more preload, you don't raise stroke volume, but you might cause pulmonary edema. And so the big question on rounds is, if I give fluids, will the stroke volume get better? And will that contribute to hemodynamic stabilization? And how am I going to answer this question? And we also recognize that context matters here, right? So if a person has a normal ventricle, giving preload will potentially cause a pretty substantial increase in stroke volume. If you have a patient with an abnormal left ventricle, not so much. And this is why maybe you give 250 cc boluses or 500 cc boluses and check again for these patients who have heart failure, because very quickly you will not see an increase in stroke volume, but you will see side effects. So I think we all agree these are important questions to answer. So now the introduction to the Swan-Ganz catheter. So this is Swan. This is Ganz, okay? And in 1970, they described in a landmark article in the New England Journal the catheterization of heart in man using a flow-directed balloon tip catheter. And what they did here is that you float the balloon tip catheter, inserted into the right atrium. You see a right atrial curve, right ventricular curve, PA curve. You see the diastole changes, and then you wedge, and you see a totally different waveform. And now you know that you're wedged into the distal pulmonary artery, and flow stops. And now, by the magic of physics, you know what the filling pressures are in the left atrium. So you learn a lot of really cool information. So this is the original study, in the New England Journal. And suffice it to say, this was transformative. So a few years later, the swan was used quite commonly in the MICU. And it can tell us a lot. It can tell us the left atrial pressure. So now you can know things about, preload. You know if the patient's at risk of pulmonary edema, if the wedge pressure is very high. You can use thermodilution and the Fick equation to figure out cardiac output. And by that, you can calculate pulmonary vascular resistance, and you can calculate systemic vascular resistance, like all these numbers that we wanted to know at the bedside with our patient. You can use it for management. If the cardiac output's low and they're dry, you give fluids. If the cardiac output's low and the preload is adequate, you start your inotropes because the heart's not working. If the cardiac output is high and they're still hypotensive, you start vasopressors. And as an early fellow and junior faculty, we did this all the time. If you were admitted to the MICU in the early to mid 1990s and before that in the late 80s and you were in shock, you got a swan. And we did countless swan-Ganz catheters in our MICU here and everywhere. And so the first question you might ask yourself is, does the swan tell us what you might want to know? And so you'll note the name here, Alfred Connors, who is the author of the main study that we're going to talk about in a few minutes, published a study in the New England Journal in 1983, where he basically asked physicians in the ICU to predict, based on their clinical evaluation, if the patient was in pulmonary edema, is it cardiogenic or non-cardiogenic? If they're worried about left ventricular dysfunction, predict the wedge pressure, predict the cardiac index. Can they say if somebody's septic or not? And so basically what they did is they showed that the percent of accurate predictions was extremely low. The ability to predict the right atrial pressure, the pulmonary artery pressure, the wedge pressure, the cardiac index, very, very low percentages of accurate predictions. So the point that Connors was making in the study is that but for the PA catheter, clinicians at the bedside could not figure out what these basic measures were. Sometimes you'll see people talk about the risks of PA catheters. These are some of the major ones: pulmonary artery rupture. I know that when we take care of Indian Phillips patients and the PA pressures are really high, we do worry about this. Pulmonary infarctions, if you become wedged. So when we were using this all the time, you had to go by and keep making sure that the patient wasn't in a wedged position. And as the catheter became soft over several days and you kept it in, it would tend to migrate out. You'd have to pull it back a little bit. You worry about arrhythmias, particularly as you're passing through the right ventricle, and access-related complications like infection and pneumothorax. But the truth is that the complications related to PA catheter were not on this list. It was actually something more sophisticated. So I'm a big fan of trenchant editorials, and this is probably one of the most trenchant of all editorials. This is Eugene Robin, who wrote a piece in the Annals of Internal Medicine. He was one of the great skeptics of PA catheters, and I'm just going to quote him. So this is when the PA catheter is becoming essentially universal in the MICU. He said the use of the Swan-Ganz catheters has increased exponentially during the past 10 years. This increase has occurred without firm evidence of an acceptable clinical trial establishing the benefits of their use exceed the risks. Then went on to say the facility in the use of the catheter has become an integral part of the job description of members of ICUs. So you could not imagine being an intensivist without using swans all the time. It was like part of our reason for being. The problem is shown by several studies that conclude that the use of the catheter is more accurate than simple clinical evaluation of patients. That was that study I just showed you. But even if true, this assertion begs the question. The real issue is whether the use of the catheter on balance salvages or improves the lives of patients or of critically ill patients generally. So in other words, all well and good to know the numbers, but are you saving lives, right? Are these patients better off because you put the catheter in? And the widespread use of pulmonary flow catheters, like many other practices in medicine, is a form of cultism. Okay. So back to Dr. Connors. so in 1996, Dr. Connors did a study that actually used the support population. So the support population was a cohort of patients who were being evaluated for end-of-life interventions, but they were all by definition critically ill. And so what he wanted to do is examine the association between the use of the right heart catheter during the first 24 hours of care in the ICU and how that related to subsequent survival, length of stay, intensity of care, and cost of care. And so it was a prospective cohort study in 5 US teaching hospitals, 5,735 critically ill adults who were receiving care, and he used propensity score and case matching using a huge number of variables to try to match people with and without the catheters based on other clinical characteristics. And here's the key figure. If you look at follow-up time and proportion of surviving, you are more likely to survive if you didn't get a right heart cath. So, and what he said is that it was patients with a right heart cath had an increased 30-day mortality with an odds ratio of 1.24, okay, of you're more likely to die if you had a swan placed. This was true in patients across the board, interestingly, not in heart failure patients, but acute respiratory failure, multisystem organ failure, and the whole population in general. And I'm sure many of you will say, you know, a cohort study that's not a randomized controlled study has its potential weaknesses, like even propensity matching doesn't necessarily eliminate all potential confounders. But still, like, provocative, right? He wasn't able to show that it helped. And it also increased resource utilization. It was more expensive. You spent more time in the ICU if you had a PA cath. And so it caused the critical care community to start to dig in. And I can't overstate like what it was like at critical care meetings at that time. Just arguing like, this is our bread and butter. Somebody actually did a study showing that what we do every day may be harming patients. Something we assume you can't practice without may be harming patients. But just look, so this is a study by Osman in critical care medicine a few years later, just looking at this basic question, response to fluids versus non-response to fluids, and showed there was no difference between the wedge pressure in those two populations. So it's first of several studies that's showing that various measures didn't tell you whether people are going to respond to giving fluids. And I think most sobering of all was the series of studies by Iberti, who's from Mount Sinai, who actually asked the question is, do physicians and later nurses know how to use this catheter? And he and his colleagues created a study with 31 questions asking, like, can you interpret this wedge pressure? Can you recognize complications? Do you understand the indications for using swans? And the responses to the questions were abysmal. So you would hope that if there were 31 questions and we're certified intensivists, you'd get 31 questions right. And the average score among attendings were in the 20s and about the same for fellows and residents. The interns didn't do quite as well, but the point, but I'll give the interns some slack, right? But the fact is that the attendings were getting a lot of these questions wrong. And when you look at the various subject area questions like insertion techniques and complications, cardiac physiology, interpretation, application of data, you'd fail your high school tests. Okay, with 67% right, 65% right, et cetera. So the concern was that people were using these catheters but really didn't know how to use them. And just to give you an example, so this is from the original test. And so what he's basically showing here is PA pressures, wedging the catheter, and basically ask the question, like, what's the wedge pressure here? And this is going to blow your mind, but the right answer to this question, I'm not going to put anybody on the spot, was 20. But then a few years later, Paul Marek was looking at this study and said he actually thinks that the questionnaire was wrong. And what he talked about is a certain aspect of physiology that we don't talk about, is that you wedge the pressure, you have to wait several beats for equilibration to occur. And that the right answer was not 20, it was actually 10. So the questionnaire itself, he called into question. So the point is that people using the PA catheter were not using it correctly. And so now, 2002, this is a study by Rhodes, basically looking at now a randomized controlled trial of the PA catheter in critically ill patients and looking at things like 28-day mortality, length of stay, and basically showing no evidence at all that using the PA catheter saved lives. And I think the summary is worth reading by Rhodes. That this study suggests that the PA catheter is not associated with an increase in mortality in critically ill patients. I find that to be a very interesting framing. But just remember, just a few years earlier, the concern was that Connor showed that mortality was increased, and everybody was all upset about that. I might have said that there's no evidence that the PA catheter helps, but his conclusion was that it didn't increase risk of death. And it was suggesting that more studies needed to be done. And indeed, more studies were done. And there's been no study that I'm aware of in the average critically ill patient, sepsis, ARDS, that shows that PA catheters save lives. So we rarely use them. I mean, our use in the ICU is mostly when we have a pulmonary hypertension patient up there, which we can talk about. So what replaced the PA catheter? Pulse pressure variation with A-line, right atrial pressure, CVP variation, ultrasound, which we use all the time, passive leg raising. All these are designed to ask the same question, like, will this patient respond to fluids? Where are they on the Starling curve? Other methods like fluid challenges, capillary refill, central venous sat, all ways of asking, how do we figure out the hemodynamics? But I ask, are these approaches any better? How do we know that all of these techniques that we use day in and day out are actually saving lives, or that we're even using them correctly? And I would submit to you that we don't know. And I'm sure that you all know that just a few weeks ago, there was a study in the New England Journal looking at the use of A-lines in patients with septic shock, and showed no evidence that patients who got A-lines had a better chance of survival. And these authors, and I remember the editorialist said, we should probably really stop using a large number of the A-lines that we're using. So I just think all these studies, all these techniques, I think, are potentially subject to the same questions. Are we using them correctly, or are we saving lives? So just to conclude this section of the talk, I think technology that yields hemodynamic data doesn't necessarily translate into improved outcomes, particularly if it's used incorrectly, used indiscriminately, and if the treatments that we use in response are ineffective. Widespread use of technology often occurs in the absence of persuasive evidence. And I think we should ask ourselves, what else are we doing in the NICU that ought to be reconsidered? Okay, so the last part of my talk. So 50-year-old man comes in with influenza, intubated for rapidly worsening oxygenation. We diagnose ARDS, and the question is, how should you set the ventilator? And I don't know, I'm gonna ask open evidence. We're all excited about AI, and you can get it right there. What ventilator setting should I be using? And it says right there, the Society of Critical Care Medicine recommends lung protective ventilation for 8 cc's per kilo, plateau pressure of 30. And if you don't read any more, you've got your answer, right? And I'll submit to you that this question is more nuanced, and so is the answer. And this is an example of how AI can give you a quick answer, but can also miss the point. So why low tidal volume ventilation? So this is a classic figure that many of you have probably seen. It's a rat model where they took healthy rat lungs and basically ventilated them with a little bit of higher pressure, 45 centimeters of water pressure. And you can see over just about 20 minutes or so, you can cause a lot of very severe damage to the lung. And this is one of the first of animal models that suggested this concept of ventilator-induced lung injury. And Gattinoni, an Italian investigator who just passed away a few weeks ago, introduced this concept of the baby lung. And this is this classic CT scan that he showed that in a patient with ARDS, there's very little normal lungs. So if you use the same tidal volumes that would use on a healthy lung, it's if only a small part of the lung is ventilating, you're basically proportionally giving high tidal volumes in this small region of the lung. And this was the argument that we should be using much lower tidal volumes in patients with ARDS to avoid the ventilator-induced lung injury. So this is the classic big transformative ARDSNet study where members of the network in the United States enrolled 861 patients, randomized to either 6 cc's per kilo ideal body weight versus 12 cc's per kilo ideal body weight. And for the trainees in the audience who think, who would give 12 cc's per kilo ideal body weight? I will just tell you, before this time, we would say, how heavy is this patient? Oh, they're 70 kilos. Let's give 700 cc's tidal volume. That's how we decided tidal volumes. You just took the weight and multiplied by 10. We just didn't know any better. And so that was what was really quite profound, was to use these lower tidal volumes. And here's the protocol. If you're in the MICU today at Yale and you want to put somebody in ARDSNet protocol, the respiratory therapist will be happy to help you. And basically, they were comparing 12 cc's per kilo versus 6, limiting plateau pressures to 50. Can you guys imagine like having a patient with a plateau pressure of 49 and thinking that it's okay? But we used to say that's what you needed to do to get good blood gases. And they went down to 30. And I want to just highlight that the protocol basically adjusts the PEEP and the FiO2 based on the patient's blood gases and SATs. Okay, which I hope makes you think like, wait, if we're worried about ventilator-induced lung injury, why are we setting the ventilator based on the blood gas? Okay, and I'll come back to that. But basically the FiO2 and the PEEP is adjusted based on the SAT, aiming to be in this range of 58 to 80 PO2 or 88 to 95 SAT. And here's the key table from the study. Patients who got lower tidal volumes had a mortality of 31%. Patients who had the higher tidal volumes had a mortality of close to 40%. The patients with lower tidal volumes were more likely to be off the ventilator after 28 days. They had more ventilator-free days. They also had less multi-system organ failure. So this was a transformative study. This is really one of the first ARDS studies that showed that you could save patients' lives based on the way you set the ventilator. And what they showed is that for most patients, if you divided them into subcategories of compliance, so less compliance, maybe a little better compliance, you would actually decrease mortality going from higher to lower tidal volumes. Interestingly, and we'll come back to this again in a few minutes, the patients with the best compliance, it was hard to show that the lower tidal volumes actually saved lives. So this was a huge accomplishment. They were able to show that the critical care community could work together and collaborate in a network. I think it's clear that lives were saved by using lower tidal volumes, that showed that this is a protocol that was feasible and generalizable. I think you can conclude that at least the average patient is better off with 6 cc's per kilo than 12. So lots of debates ensued. Was 12 dangerous or 6 better? I mean, not really answerable. It doesn't account for later therapies that came along, which is one of our limitations in critical care in general, like the use of corticosteroids and neuromuscular blockade and proning, all of which are now recommended therapy for ARDS patients. The number needed to treat was 11, which, as number needed to treat goes across the literature, is pretty good. But you don't know if it's 10 neutral and 1 saved, or 5 harmed and 6 benefited. I mean, I think that it still leads to the question of like who are the patients who will save? And you can imagine how people might be harmed with the ARDSNet protocol, as helpful as it might seem. Should we be fixated on tidal volumes as the best target? Does one size fits all? Should everybody, like open evidence suggests, have the same tidal volume? Should we rigidly adhere to this protocol? Like as an ICU director, Shoko doesn't want chaos in the ICU, everybody with different tidal volumes. But on the other hand, like, must you be on this one thing? No. And why are the ventilator settings being set by blood gases as opposed to mechanics, which was the whole point, to avoid ventilator-induced lung injury? So Kurt Weiss, who's a former resident here and went on to do his pulmonary critical care training at Northwestern, actually did some interesting work as a junior faculty member out there that showed that even years after the ARDSNet study was published, that the uptake was actually pretty poor. Well under half of patients who had ARDS in ICUs that he studied were actually put on low tidal volume ventilation. I think these numbers are lower than our numbers for reasons we could get into, but certainly not universal. And the question you could ask was, is this a quality issue? Like, are people just not using state-of-the-art therapy, or do the physicians know something that leads them to want to manage patients in a different way? And there are now sort of emerging literature suggesting that when you look at different patient populations, the low tidal volume ventilation probably makes a difference mostly in patients who have poor lung compliance. So this is a study by Ewan Gallagher that was published in the Blue Journal 5 years ago that basically looked at high tidal volumes versus low tidal volumes, where he was looking at median elastance, which is the inverse of compliance. And what he showed was that if you looked at the risk of mortality at day 60, it was only at the patients with the worst lung mechanics that seemed to benefit from using a low tidal volume strategy. Other people have started to become very excited about the use of driving pressure as a technique for determining tidal volumes and PEEP. And the driving pressure is basically the plateau minus the PEEP. And it comes from studies like this by Amato that basically showed that mortality rises dramatically when the driving pressure on the ventilator settings goes above 15. And there have been suggestions that driving pressure, not tidal volume, should be what we're using to set the ventilator. And hate to break it to you, but there's no evidence that using driving pressure as a protocol saves lives. But it at least does show you that other parameters matter. And if you look here, this is a study looking at people who have poor compliance and low compliance. And if you have higher driving pressures in people with low compliance, the odds of dying go up quite a bit. On the other hand, if a patient has a good compliance, going to lower driving pressures, actually, if anything, they increase mortality. And here's where I'm going to look at Lauren Ferrante and say, like, we need to wake these patients up. We need to walk them around. If you're forcing them to have, like, they have milder lung injury and you're forcing them to be sedated and paralyzed and use lower tidal volumes, you may actually be buying toxicity when, in fact, they really should be awake and getting trialed and extubated. This is also something that I picked up on, and I think many of you may have picked up on during the COVID pandemic. This is sort of a composite patient when I was on 15's North Pavilion that year. A patient with ARDS on FiO2 of 100, PEEP of 20, tidal volume 4 cc's per kilo, so really low. PO2 is only 50, plateau pressure is 34, and I followed the ARDSNet protocol. And so I put the PEEP up to 22, and now things are even worse. Like the PO2 drops to 45, the plateau pressure rises to 40. And so what do you do next? Do you call the ECMO team? Do you decrease the PEEP? And in fact, I think I'm not the only one who saw it go down on the PEEP, and the patient's blood gas improved, and their plateau pressure went way down. And so this was an example of non-recruitability, which is not something the ARDSNet protocol takes into account. And so if you look at ARDS patients, you can roughly divide them into people with non-recruitable lung and recruitable lung. And so in the B figure here, this is a patient with 5 centimeters of water pressure applied and 45 centimeters of water pressure applied. And if you're recruitable, you should open lung up. And you see that these CTs look exactly the same. So this is non-recruitable lung. In contrast, patients with recruitable lung, you can see how the infiltrates, the opacities clear when you apply the pressure. And so it really would seem important to know when you're adjusting the ventilator, whether you're actually doing what PEEP is intended to do, which is to recruit lung. And remember, the plateau pressures we think of high plateau pressures as representing people who are overdistended. But just a reminder that high plateau pressures can also be due to massive obesity, tense ascites, chest wall abnormalities. And it's very hard to take that into account when you're not directly measuring plateau pressures in the MICU. And as I'm sure many of you know, there are studies looking at use of balloons to measure esophageal pressures, but not used routinely. But it's just to say that we don't really know what these pressures already mean. So there are a lot of people who are interested in this idea of titrating PEEP to optimize compliance. And this is just an example of a protocol used at Mass General, where they actually just titrated PEEP up, looked at what happened to the plateau pressure, looked at what happened to the compliance, the driving pressure, the PO2, and the blood pressure. And what they showed is that you can titrate PEEP and identify ideal ventilator settings. And when you go up higher on the PEEP, the compliance goes down. Okay, the PO2 goes down. So there's like a sweet spot here. And the argument is that maybe what we should be doing is doing this with all our patients. Again, the concern is that even true? And the hour's getting a little late and I want to leave time for questions, but if you want to read some really good editorials, John Marini is one of my heroes in critical care. And the sum of all these quotes is to make the point that randomized controlled trials are composite population studies. And when you use protocols that basically force you to use the same protocol for diverse patients, you may find yourself rigidly having to do things that you think are actually wrong. And that a physician at the bedside may want to craft individualized ventilator settings to meet the patient's needs. And this is sort of the challenge. Is that a good thing to do or not a good thing to do? But just to be aware, there's lots of variability in our ARDS patients and lots of studies being done to look at how do we optimally manage them. Different types of lung pathology, different causes of ARDS, different severity of hypoxemia, different lung compliances, pleural pressures, recruitability, dead space, hyper and hypoinflammatory conditions, all of which have an impact on the therapies that we choose. All ARDS is not the same. So just to summarize here, I think low tidal volume ventilation almost certainly has led to a net lives saved. Protocols are better than chaos, but rigid adherence to the protocol almost certainly harms some patients. I think individualized therapy may be better, but we still don't have evidence that individualized therapy is going to be helpful. So my final thoughts on zombie studies. I think they were landmarks in their time. They were rigorously done. They deserve credit for that. I think they transformed critical care for the better. But they became zombies because I think they're misunderstood, misquoted, sometimes misapplied. And I hope that my exploration of these studies today will put these studies back in their rightful place as important landmarks in the critical care literature. But I also hope sort of stimulate you to think about studies being done today and what we'll be talking about 30 years from now. So I am happy to entertain questions. Thank you.
Thank you so much. I learned a lot. Super thought-provoking as I expected it would be. I learned that your knowledge base plateaus after your internship year and that intensivists are cultists. That sounds about right. But I'm opening up for some questions. I see Dr. Yagi has one.
Thank you, Mark. That was awesome. A trip down memory lane and really clinically thoughtful. I want to focus in on the second study, the right heart cath study. And when I was a fellow in 2000, 2003, it was malpractice not to put in a right heart cath if you left the ICU in a hypotensive patient. And clearly that was not appropriate care. But I also worry sometimes that the pendulum has swung too far the other direction, and whether to expect a mortality benefit in a diagnostic test, where we're not even looking at whether management was changed as a result. And I think that the problem we have now is people don't know how to use these at all, including the nurses in the ICU. And I think in support of that is they're making a bit of a resurgence in the CCU right now in cardiogenic shock. And I've recently used one at the bedside in a patient that we couldn't otherwise answer the question. And so just your thought.
Yeah, so for those of you who have the privilege of rounding with Clar in the MICU, he always gives his swan talk to this day, and I appreciate that. I think you're addressing some really important issues. As you know, Elliot Miller gave pulmonary grand rounds. Not that long after that, Tariq Ahmad gave medical grand rounds. They had completely different views on the use of PA catheters in the CCU. So just to show that there is debate there. I do think that the issue of de-skilling is an issue, and Clemente may have some thoughts about how the fellows in future years are going to get A-lines done if we're not going to use them. But having said all that, I think that the questions remain. I didn't give this talk to be nihilistic. I do think we need to know why our patients are in shock. I do think it's better to know than not know. But I also think we should remind ourselves that not everybody's using the technologies correctly. The treatments have to be studied in and of themselves, right? So if you know the patient needs more preload or is preload responsive, but they're going into worse pulmonary edema, they're also leaking all the fluid that you're giving them. So I think it's just a call to be thoughtful and understand the technology and its limitations and to study it rigorously. Isabel.
Oh, hello. Okay. Hi. Thank you so much. I am shocked that people survived the MICU with all the PA catheters and the 12 cc's per kg tidal volumes. That is wild. My question is about how you have adopted change. Clearly, a lot in practice has changed from when you were graduating from your training to now, and you've shown that today. How easy are you to adopt a change with a study that looks like a landmark study? And I'm sure there have been times when you've been burned by adopting a change that ended up not being helpful, maybe to your patient, or maybe overall that study eventually got debunked. And I feel I'm starting to notice that in my practice, where some of the things that are being recommended now are different than what I learned a few years ago. And so what is your threshold, or how do you consider yourself as either an early adopter or a late adopter of some of these changes?
Yeah. So I'm not a cynic. I used to be an earlier adopter, and I don't consider myself a late adopter. But I do think that what I have learned over the years is that over over decades, you see the context of where these studies fit in. What's also happened over time is that we really are intolerant. Look at the numbers of patients studied. Like, you could get New England Journal with studying 25 patients in the 1980s. Now you need thousands. You can't just do single center studies anymore. You have to do multi-center studies. You have to do prove it with second studies. And so I think it's just to be humble and understand the context. And I'm a big advocate of using Bayesian reasoning here. Like if a study, this is one of the quotes that I think was in Marini, is like when a finding contradicts everything you believe, the likelihood that it's real is lower. And to just be aware of like it has to make sense and things like that. I don't think there's any simple answer, just to realize it will continue to evolve. Mortality is lower, as you pointed out, than when I was a fellow. And I think that's hopefully because we did move the pendulum in the right direction.
There are several questions from the Zoom world, but we'll take one. This is from Kathleen. Outstanding talk. Thank you, Mark. always learn so much from you. I do wonder where you envision computer-assisted interpretation of such tools, AI guiding bedside clinicians in managing critical illness in the future.
Yeah, thank you, Kathleen. So I actually am a relative optimist about the use of artificial intelligence and computer information, but I think I would make the same comment that I was implying from the open evidence slide. I think you have to be an informed consumer. I'm so glad Sandy just walked out, but I was going to say I'm so glad that Sandy and others are and Brian are giving the ventilator talk. I think that to surrender the mechanics to a machine and not knowing it can't possibly be the right answer. But I also am optimistic, to Kathleen's point, that we may learn a lot using AI intelligently. But I also think it should be studied rigorously, like these other technologies.
One last question, because this is such a fantastic talk and I've been given leeway that I can go a couple minutes. Oh,
yeah, thanks. Sorry, it's actually just a quick comment and follow up to a point you made. So with the A-line study, I think Haley wrote the editorial, Haley Gershengorn, and she is all fired up on this issue. She's like anti-A-line now. But last week, we were all at SCCM, or a lot of us were at SCCM, and there were a couple of new guidelines presented, including the update to the Surviving Sepsis campaign. And one of the questions they addressed was this exact issue. And actually, they got it right. So I would suggest that everybody take a look at it, where they recommend against the use of it if someone's on, one low dose pressor, or if invasive strategies are possible. But if somebody is very large and you can't get a good, non-invasive measure, or they're on escalating doses of pressors, then they recommend placing an A-line. And so, I think, I recently chaired a guideline that was presented last week. I have like a new appreciation for this because they're looking at all the pooled meta-analyses and not letting just one study like totally change their practice. And so it was really nice to see that this guideline group got that right in terms of the A-line recommendation. It like makes a lot of sense with our clinical practice. And then the other thing is the driving pressure. We will have an answer in a few years because there's this very large trial being done called Prevent Villi, funded by NHLBI. The problem is it's a 7-year trial, and I think they're in year 2. So we're going to have to wait a few years, but
yeah.
Yeah.
I appreciate that, Lauren. I've gotten into debates with my up-to-date co-author on mechanical ventilation and ARDS about whether we should recommend driving pressure or not. And I think we've sort of come together saying, wait for the study to be done. And I think to your point about Haley's editorial and the SCCM recommendations, I think it's just a really good reminder. And also, I think to Clara's point earlier, that these are not blanket recommendations. I do think you understand the context, like a person who can't measure the blood pressure any other way, or keeps dropping their blood pressure every 3 minutes, the cuff pressure is not going to work. And so the point, I think, of her editorial was really like across the board, everybody does not need an A-line. Some people may still need an A-line. So thank you.
thank you so much for the wonderful talk.